So, now, of course, there are things I want to mention about this condition and things I have to mention about this condition. Now, first of all, of course, resistance to treatment in ADHD. How should treatment be regulated? Of course, ADHD responds very well to treatment as a disorder, as disorders go. As Professor Knight has said, just like autism or bipolar disorder, ADHD is not like those. They respond very well to treatment. However, you have to abide by certain principles. You have to know it's a chronic disorder. In treatment, there are two methods, psychopharmacology and behavioral therapy, and apart from that, I know of no very effective treatments. Of course, psychoeducation should be for everyone, but that's not behavioral therapy. You should know that. Informing the patients about the disease is something that you have to do for everyone. It's not a special treatment method. As you know, this ADHD treatment, this is the study that all our knowledge stems from. Everyone knows this very well, so I won't elaborate. When you look at core signs, we see that drug treatment is the most efficacious one, but algorithmic drug treatment. Fourth is what we call the social treatment. People coming to polyclinics and being taken care of by pediatricians or other healthcare professionals. Now, with this treatment and algorithmic treatment, within these two, there's a difference. What's the difference? It's the medication dosage. And, of course, the visits are different. This issue of medication dosage we'll come back to later. And there's also the other basic therapeutic method. Apart from psychoeducation, it's this behavioral therapy and family-focused interventions. 10 to 20 sessions, each lasting 1 to 2 hours, where we're focusing on children's behavior, instituting rewarding systems at home, effective use of breaks, and coping with inappropriate behavior in other environments. These are very effective, of course, and if there are pronounced problems with the family, there has to be family therapy. Behavioral therapy is fine, but of course it doesn't have an additive effect to cognitive. Diet modification, no effect. Neurofeedback, etc., of course, no effect. So, what is recommended for treatment? First of all, and these are the recommendations of the American Academy, so these are FDA-approved drugs, which are, as we know, stimulants and atomoxetine. When we look at stimulants, response to treatment, when we give one stimulant, it's between 65 to 75%. And this is something we observe in the clinic. For instance, when you see 40, 50 patients a day, once you diagnose, you give the medication and tell of the side effects. When you finish the box, come see me. Well, 3/4 of them get better. You don't provide behavioral therapy for them. They get well. I see a lot of patients, and I think this is valid for many of them. This shows that stimulants have a larger effect size compared to placebo. And among all psychotropic medications, these are one of the most efficacious ones. And antibiotics, painkillers, everything, when you compare them with those, these are medications that have been worked upon the most. There's around 350 double-blind placebo-controlled studies. All side effects, everything about those medications are known. Therefore, when they're prescribed, they are very efficacious. We know that long-acting stimulants are also there. These are as efficacious as short-acting ones, easy to use, and children feel more comfortable because, of course, at school, there are no nurses or anything. The teacher says in the middle of the class, come take your medication, and children refuse. So therefore, having them once a day is efficacious. Short-acting forms are for children lower than 16 kilograms in preschool children. Instead of long-acting ones, we start with short-acting ones. Now, here, this I won't be talking about adults, of course, but the average effective dosage in adults is 88 milligrams. In an 88 milligram treatment, it is 76% efficacious, which shows that in adolescents, in those people above 50 kilograms, we have to keep the dosage high. If, for instance, 30 milligram short-acting methylphenidate and no response, that does not mean no response on the part of the patient. But 88 milligrams is a very high dose, of course. It's not something we're prescribed, but I guess this is the way it is. I know, for instance, among our colleagues, there are even those who hesitate about prescribing 54. 54 milligram Concerta is very effective on children of 8 to 9 years of age, and therefore we should not be too concerned about the dosage, because there is a linear relationship between dosage and response. The higher the dose, the better the response, until such time as side effects emerge. I know you cannot see this. For those about 50 kilograms, Concerta dosage is maximum 108 milligram, it says. FDA approved is 72. So until 72 is FDA approved, until 108 it is acceptable, as long as there are no side effects. For 72 it's reliable, yes. For 108 it's effective, but at your own risk. Now here they've also shown there's big difference among patients. 1/3 of them responds to dosages below 15 milligram, 1/3 between 50 and 35 milligram. These are, of course, short-acting dosages, and 1/3 respond to dosages above 35 milligrams. So therefore, what's generally said is start with lower dosage and elevate as necessary. Is not a bad tactic, because 1/3 of patients will respond to a lower dosage, but those who respond to a lower dosage, they also need to increase their dosages later on. So starting with the shorter dosage does not mean you're going to be able to stay there for a long time. Now, and the method they recommend is this. They say increase the dosage every 1 to 3 weeks, and either achieve remission or the maximum recommended dosage, or have the side effect emerge. So do not stop increasing dosage of the medication before either of these emerge. So don't stop at partial remission. Continue increasing the dose. If there's side effect, lower the dose. Or when you come to maximum dosage per kilogram, stop. But apart from that, do not put forth a psychological level by yourself and stop there. Of course, amphetamine and MPH, when you look at those two, it has been shown that 45% of the patients respond better to one of these medications. So it's 85% the likelihood of responding to one or the other. So that's a big percentage. But what is our problem? For instance, varieties of medications are limited here. We should have more medications. When you cannot use 2 stimulants, you automatically reduce the efficacy of your own treatment by 15%, which is not rational. Atomoxetin. Atomoxetin is an efficacious drug. 0.7 effect size compared with placebo is good, but considering stimulants have 1, then compared to stimulants, this is a lower effect size. Acceptable side effects. When you use it in the clinic, it's observable. By the end of the first box, there's some kind of improvement with the patients, but as you continue to use the medication, the effect increases, and the trials say that efficacy will be maximized by week 6, and do not stop earlier, trials say. As I said just now, atomoxetin and MPH comparison trials show that stimulants are more effective. Stimulants seem to be more logical as a first choice drug, but anxiety disorder, tic disorder, other comorbidities with regard to using one single medication, atomoxetin, is advantageous. And another advantage is efficacy continues in late hours of the evening. For this, they tell that we should be dividing into 2 dosages. It can be used in one single dosage, but if you divide it into 2 medications, it will be more efficacious. There may be 2 side effects. They say one is hepatotoxicity, the other is suicidal ideation, but the ratios are so low that especially the routine monitoring of liver enzymes are not recommended. When we look at meta-analysis, number needed to treat an NT, we talked about this yesterday as well. You have to see 3 patients for the effect to be observable. So one of the patients will improve out of 3. This is not a bad number at all. 3 is a good number compared with other drugs. And at the outset, those who are worse improve better. In hyperactive, impulsive people, response is lower. We know the side effects. The more effects in those who start out as more hyperactive. Another recommendation is, if there's there's still no response, then review your diagnosis. 85% is a very high clinical ratio. If you have come to the maximum dosage and there's not enough response on the part of the patient, then review your diagnosis or add other medications or go for behavioral therapy. As you can see here, the problem here is this. Attention deficit particularly. Attention is a very upper level function. So there are many diseases and variables which have an impact on attention. It may be situational, it may be anxiety related, depression related, mania related, schizophrenia related. In all psychiatric disorders, attention is already deficient. So when you see affective disorders, it is said that are these comorbid or is this the basic kind? Check for these. If you are trying to treat depression as ADHD, that may be why you're not getting a response. As we know, bupropion, TCAs, alpha agonists are being used, but they are much less efficacious compared to other drugs, and their side effects are high. Tricyclics should be monitored, followed up by a cardiologist, as the efficacy is comparable with behavioral therapy. So maybe we should first be using behavioral therapy. It may be more advantageous for the patient. There's modafinil, very little side effects, but Steven Johnson-like decubitus may happen. Side effects I'll skip. And of course, the physicians and the patients believing that the medication is not efficacious is the increase of signs towards the evening or the emergence of aggression on the part of the patients. And it is said that stimulants, in fact, do not cause aggression by themselves. What is seen more frequently is the rebound effect towards the evening, and this misleads people to think that the medication is not efficacious, whereas what we need to do is to add a short-acting stimulant in the evening or atomoxetine. Then you kind of prolong the effect period. Okay, as we just said, if there are comorbidities or if there is family history, there will be psychosocial treatment addictions. As we said just now, behavioral therapy is effective. But this is interesting. This MTA treatment in the first 14 months, therapeutic success was high in drug therapy. As they followed up the patient, the difference of the treatment from the placebo reduced because some of the patients improved spontaneously. So that's why the difference is narrowing down. And there are 3 probabilities. When you follow them up for 2-3 years, it's either of these 3 groups. There's slow improvements at the outset, and the improvement increases later on and stabilizes. First, there's big improvement, and then they keep it for 3 years, and then there are those improvements at the outset, and then the effect disappears. The last group is children with low IQ. The ones in the first group, if they're continuing the medication during the 3-year follow-up, they do fine, whereas the ones in the second group, they're fine even when they don't use the medication 3 years later. So this group, we don't know the biological differences, but this group is different from the rest. I'll skip those because what I really want to do is to say is, because I have run out of time, I know, these differences stem from this. ADHD is not a homogeneous disorder. It may have at least 2 different subtypes, both dopamine-based. One of these is the motivational style disorder. I won't go into details, but the problem here is these are, compared with the other group, those who have disorders in thought and motion, it's a different thing. Families say, my child can focus his attention, but not on this class because it's a problem of motivation. Motivation means dopamine. Because motivation has an effect on dopamine levels, some people may respond to less treatment or respond worse to more treatment. As I said, there's no time, I can't go into it, but those 2 systems belong to 2 different parts of the brain, it seems, so therefore some people respond better to medication and some respond worse to medication. And the last thing I'm going to show is, this is something I like very well. I think many things are related to this. This is something that is found in Parkinson. Here you can see better. What we see here is, this is different for different areas of the brain. It's something that may shift to the left or to the right. It's different for orbitofrontal, different for dorsolateral. It's the inverted U. Arousal increases to a certain point. Cognitive arousal increases. After a certain point, cognitive arousal comes down. Our medications push dopamine up. Therefore, stimulus is shifted towards the right. Depends on where you stand. If at the outset you are a bit higher up, for instance, if you're about here somewhere and you have a motivational problem, then what you need to use is this medication. It will take you up there even faster. And if you take more, you'll shift over to this side and you start experiencing performance problems. But if you're in the other group, maybe you're up here and you need a higher dose to go up there. So therefore, maybe some people are more over here, and because of comorbid situations, they may be different, or maybe some are here, so that's why their dopamine levels change fast. This is not something that is known very well, but I guess this will be researched. Thank you.